Good day. This is Janella P. Arceo, and in this presentation, we'll talk about the basics of thyroid cancer. Here's an outline of the presentation: introduction, epidemiology and etiology, clinical features, diagnostics, and management. We'll talk about what is thyroid cancer, who gets it, its symptoms, diagnosis, and treatments. The thyroid is a butterfly-shaped gland located at the base of the neck, just below the Adam's apple. This organ also produces hormones that regulate heart rate, blood pressure, body temperature, and weight. So what does the thyroid gland do? The thyroid gland produces hormones that regulate the body's metabolic rate, controlling the heart, muscle, digestive function, brain development, and bone maintenance. Its correct functioning depends on the good supply of iodine from the diet. Here's an example of normal cells versus abnormal cells. When thyroid cells mutate, a change in their DNA occurs, which makes the cell grow and multiply. Normally, the healthy cells die, but with these abnormal cells, they continue to grow and grow until eventually they form a mass called tumor. Sometimes, these cells invade nearby tissues and can spread, or worse, which can even metastasize to other parts of the body. Thyroid cancer incidence rates have increased in many countries and settings. However, mortality rates have remained stable at lower rates. This epidemiological pattern has been largely attributed to an overdiagnosis effect. There has been a recorded incidence rates 1.1 per 100,000 of women and 3.1 per 100,000 of men. In both sexes, incidence rates were 5 times higher in high human development index countries than in low and medium human development index countries. There has also been a recorded highest incidence rates being in the Federated States of Micronesia and French Polynesia, North America, and East Asia, particularly South Korea, even reaching 45 per 100,000. Timely evidence for the global epidemiological status is necessary to identify the magnitude of this problem and the areas mostly affected by it. There has been a recorded mortality rate of 0.5 per 100,000 of women and 0.3 per 100,000 of men. This result has been relatively similar across the different settings. Mortality rates were less than 1 per 100,000 in most countries and in both sexes. South Korea had the highest incidence to mortality rate ratio in both sexes, followed by Cyprus and Canada. The current thyroid cancer epidemiological landscape is strongly suggestive of a large effect of overdiagnosis in many countries and settings worldwide, confirming the relevance of thyroid cancer overdiagnosis as a global public health problem. Thyroid cancers occur when the DNA in your thyroid cells mutates, causing the cells to multiply in an uncontrolled manner and invade locally. As these abnormal cells accumulate, they form a tumor that can then spread to the other parts of the body. It's unclear what exactly causes most thyroid cancers, though some cases are linked to inherited conditions. There are certain risk factors for thyroid cancer, including exposure to radiation, having a diet that's low in iodine, and being a female. According to the National Cancer Institute, Risk factors for developing thyroid cancer include being a female, ages between 25 and 65, median age of papillary thyroid cancer patient is 50, Asian ethnicity, radiation exposure. This includes having had an external beam radiation to the head, neck, or chest, or exposure to a radiation event such as the one at Chernobyl, which led to an increase in children with thyroid cancer. The cancer can develop as early as 5 years after exposure. A history of goiter or enlarged thyroid gland, a family history of thyroid cancer or thyroid disease, having certain genetic mutations. This is especially relevant to the medullary thyroid cancer, which runs strongly in families. If you have a family member with medullary thyroid cancer, there is a blood test that you can take that looks for a mutation on a specific gene called RAT that is associated with the cancer. People who learn that they have these mutations sometimes opt to undergo surgery to remove their thyroid. Their surgery is called thyroidectomy to decrease their chance of cancer. Even young children can have this surgery. Iodine deficiency, which is a risk factor for follicular thyroid cancer, and being overweight or obese. Heavier individuals have a higher risk of developing thyroid cancer than people who are not overweight, and the risk appears to increase as body mass index or BMI goes up. Heavier patients also often present at later stages and with more aggressive tumors. There are four main types of thyroid cancer, which are papillary, follicular, medullary, and anaplastic. Less common thyroid cancers include thyroid lymphomas, sarcomas, and other rare tumors. There are several types of thyroid cancer, but two types, particularly papillary thyroid cancer and follicular thyroid cancer, are by far the most common, accounting for some 95% of cases. Papillary thyroid cancer. This is by far the most common form of thyroid cancer, accounting for between 80% and 85% of all diagnoses. It's the most curable of all cancers. Follicular thyroid cancer. About 10% to 15% of thyroid cancers fall into this category. It's more aggressive than papillary thyroid cancer and can invade other areas of the body through the bloodstream. A rare form of follicular thyroid cancer known as Hurtle cell cancer is especially aggressive. Medullary thyroid cancer. This accounts for less than 3% of thyroid cancers. According to the American Thyroid Association, or ATA, it can, frequently does, spread to lymph nodes. Anaplastic thyroid cancer. This type of cancer has a poorer prognosis and tends to become resistant to chemotherapy over time. The ATA says less than 2% of thyroid cancers fit into this category. Anaplastic thyroid cancer advances quickly and is the most aggressive thyroid cancer. Here's a cytopathology of papillary thyroid carcinoma or cancer with typical features: papillary formations, crowded, overlapping nuclei, psammoma bodies, margination of chromatin, and central nuclear clearing, nuclear pseudo-inclusions, and nuclear grooves under pap stain. This shows a micrograph of follicular thyroid carcinoma showing a location where the cancer grows through the fibrous capsule under H&E stain. Second picture is a micrograph of a Hürthle cell neoplasm. Also, this is a high magnification micrograph of medullary thyroid carcinoma. On the lower side, this is a copy of a medullary thyroid carcinoma on ultrasound with typical small calcifications, as pointed by the arrows. This is a low magnification micrograph of anaplastic thyroid carcinoma with a component of papillary thyroid carcinoma, tall cell variant, under H&E stain. The second picture on the lower part is a picture of an anaplastic thyroid carcinoma cell. This is a diagram of how the different types of thyroid cancers are formed. Thyroid cancer frequently presents with no symptoms. Usually, a physician finds a nodule or a growth of abnormal thyroid tissue during an incidental exam. When thyroid cancer shows signs or symptoms, the most common one is swelling in your neck. Sometimes you don't even notice the growth. Other common symptoms of thyroid cancer include pain in front of the neck, difficulty in swallowing or in breathing, as well as persistent cough. Examining your neck can sometimes help you find lumps or enlargements that may point to thyroid conditions, including nodules, goiter, and thyroid cancer. You can do a test at home to help detect nodules, which, if noticed, should be brought to your healthcare provider's attention for further evaluation. Comprehensive and thorough diagnosis of thyroid cancer involves a number of procedures and tests. Usually, the process of evaluating for thyroid cancer starts with finding a lump or nodule in your gland. You may find it or see it yourself, or in some cases, your healthcare provider may detect it during an exam. It's also fairly common for thyroid nodules to be discovered when you have x-rays of your head or neck for other purposes. These are some ways on how to diagnose your thyroid cancer. First is blood tests. This cannot diagnose thyroid cancer itself or detect a cancerous thyroid nodule, but they can rule out other conditions and determine if your thyroid is working the way it should. Fine needle aspiration biopsy is a technique in which a fine needle is introduced into a mass, cellular material is aspirated, and a cytological diagnosis is rendered. Third is lobectomy, which is a surgical operation where a lobe of the lung is removed. It is done to remove a portion of deceased lung, such as a early-stage lung cancer. Next is molecular genetic testing, which is an important tool as it helps link mutations to genetic conditions, which will in turn help to search for targeted treatments and cures for various genetic conditions. Laryngoscopy is an endoscopy of the larynx, a part of the throat. It is a medical procedure that is used to obtain a view, for example, of the vocal cords and the glottis. Imaging. Imaging tests and scans are used to help find suspicious areas that could be cancer and to see how far it might have spread. It includes radiolocene scan, CT scan, and MRI. Treatment of thyroid cancer varies based on the type and staging of the cancer, as well as other factors including your age at diagnosis, your general health, and whether your cancer is newly diagnosed or recurring. Your thyroid cancer treatment options depend on the type and stage of your thyroid cancer, your overall health, and your preferences. Most people diagnosed with thyroid cancer have an excellent prognosis, as most thyroid cancers can be cured with treatment. Treatment might not be needed right away for very small papillary thyroid cancers, particularly papillary microcarcinomas, because these cancers have a low risk of growing or spreading. As an alternative to surgery or other treatments, you might consider active surveillance with frequent monitoring of the cancer. Your healthcare provider might recommend blood tests and ultrasound exam of your neck once or twice a year. These are some of the several pharmacologic treatments your physician or healthcare provider may issue to you: surgery, thyroid hormone therapy, radioactive iodine, injecting alcohol into cancers, treatments for advanced thyroid cancers, and targeted drug therapy. Thyroidectomy is a surgery to remove the thyroid gland. It is the most common surgery for thyroid cancer. Thyroid hormone therapy, which is a treatment to replace or supplement the hormones produced in the thyroid. Radioactive iodine is a treatment that uses a form of iodine that's radioactive to kill thyroid cells and thyroid cancer cells that might remain after surgery. It's most often used to treat differentiated thyroid cancers that have a risk for spreading to the other parts of the body. Injecting alcohol into cancers. Alcohol ablation, which is also called ethanol ablation, involves using a needle to inject alcohol into small areas of the thyroid cancer. Ultrasound imaging is used to precisely guide the needle. The alcohol causes the thyroid cancers to shrink or to get smaller. Targeted drug treatments, which focuses on specific chemicals present within cancer cells. By blocking these chemicals, targeted drug treatments can cause cancer cells to die. Some of these treatments come in pill form and some are given through a vein. Radiation therapy. External beam radiation uses a machine that aims high-energy beams, such as X-rays and protons, to precisely point on your body to kill cancer cells. Radiation therapy might be recommended if your cancer doesn't respond to other treatments or if it comes back. Radiation therapy can help control pain caused by the cancer that spreads to the bones. It also has side effects, which depend on where the radiation is aimed. If it's aimed at the neck, side effects might include a sunburn-like reaction on the skin, a cough, and a painful swelling. Chemotherapy is a drug treatment that uses chemicals to kill cancer cells. There are many different chemotherapy drugs that can be used alone or in combination. Some come in pill form, but most are given through a vein. Chemotherapy may help control fast-growing thyroid cancers, such as anaplastic thyroid cancer. Destroying cancer cells with heat and cold. Thyroid cancer cells that spread to the lungs, liver, and bones can be treated with heat and cold to kill the cancer cells. Radiofrequency ablation uses electrical energy to heat up cancer cells, causing them to die. Cryoablation uses a gas to freeze and kill cancer cells. These treatments can help control small areas of cancer cells. A non-pharmacologic treatment which may be given to a thyroid cancer patient is supportive care or palliative care, which is a specialized medical care that focuses on providing relief from pain and other symptoms of a serious illness. Palliative care specialists work for you, your family, and your healthcare team to provide an extra layer of support that complements your ongoing care. When palliative care is used along with all of other appropriate treatments, people with cancer may feel better, have a better quality of life, and live longer. So here are frequently asked questions. Do men get thyroid cancer? The answer is yes. Men do get thyroid cancer, but it's 3 times more common in women. For men, being over age 60 and having a family history of the disease can increase the risk. Can hypothyroidism lead to thyroid cancer? Some research has shown a greater risk for thyroid cancer among people who were diagnosed with hyperthyroidism. The increase may be partially due to the fact that healthcare providers closely monitor thyroid patients and are more likely to find cancer even without symptoms.